Medicine Made Easy podcast, prepared by Dr. Mohamedul Nagi Mohammed. Welcome to the deep dive. Today, we're really zeroing in on a topic that's so important for both clinical practice and for exams: the diagnosis and management of type 1 diabetes mellitus, or T1DM. And this material is absolute gold dust, especially if you're preparing for something like the MRCGP AKT. We're aiming for that high level of accuracy you need.
Absolutely. Our mission here is to pull it all together, go beyond just a simple checklist. We'll trace the whole journey
Right.
from that acute presentation, maybe with DKA features, right through to the specific antibody tests, and then into the long-term NICE guidance on insulin regimens and so on.
Okay, let's get into it, the acute presentation. So while the diagnosis might develop over time, the thing that actually brings the patient through the door often looks like a real crisis, doesn't it? Like diabetic ketoacidosis, DKA.
It does, and that acute picture is often the key, especially in younger patients. You have the classic things, polyuria, polydipsia, dehydration, but they're often, amplified.
And there are other signs that can be a bit distracting.
Yes, that's a great point. Things like significant abdominal pain. It can sometimes make clinicians think of, say, an acute abdomen and pull them away from the real metabolic emergency.
And the breathing. That's unforgettable, right? Those deep, labored breaths.
Exactly. We're talking about Kussmaul respiration, that deep hyperventilation the body uses to try and blow off CO2 to correct the acidosis.
And the smell.
Ah, yes, the acetone on the breath. It's often described as pear drops. If you smell that, it's an immediate signal of ketosis.
So if we see those signs, the breathing, dehydration, that smell, what's the immediate workup? What confirms it?
You start simple and fast. A urine dipstick. You're looking for glucose and ketones. That gives you an instant clue.
Okay.
Then you move to the lab work. A fasting glucose and a random glucose.
But for a new suspected type 1 diagnosis, we need more than just glucose levels, don't we?
We do. You have to confirm that the body's own insulin production has failed. The best way is measuring C-peptide levels. They're typically very low in T1DM.
And here's a key exam point. What about HbA1c? We use it all the time for type 2.
Right. But for a suspected acute T1DM presentation, HbA1c is not the right tool for diagnosis.
Why is that exactly? It feels a bit counterintuitive.
It's because T1DM often involves a very rapid destruction of beta cells. The glucose surge is recent. HbA1c reflects the average over 2 to 3 months, so it just hasn't had time to rise significantly. It won't capture that sharp, recent spike.
That makes perfect sense. So let's talk about the definitive proof of that autoimmune attack, the autoantibodies.
Yes, these are the markers of that self-destruction. The most common one you'll see is anti-GAD, which is glutamic acid decarboxylase antibodies. That's present in about 80% of T1DM patients.
80%. Okay, what's next?
Next up is islet cell antibodies, or ICA. They're present in a similar number, around 70 to 80% of patients. So just knowing those two covers most cases.
And then there's the one that's a bit age-dependent.
That's the insulin autoantibodies, IAA. In very young children with T1DM, you'll find IAA in over 90% of them. But in older patients, that drops right down to about 60%.
And the last one.
The last one is insulinoma-associated 2 autoantibodies, or IA2A. Having these antibody tests is absolutely key for telling type 1 from type 2 when the picture isn't clear.
Which brings us nicely to the formal diagnostic criteria. What are the glucose thresholds we need to know?
Okay, so if the patient is symptomatic, it's a fasting glucose of 7.0 millimole or more, or R, a random glucose of 11.1 millimole or more.
And that 11.1 also applies to an oral glucose tolerance test.
Yes, 2 hours after the 75D test.
What if they're asymptomatic? Which is, as you said, less common, but it happens.
For an asymptomatic patient, you need to show those same numbers, but on 2 separate occasions. That locks in the diagnosis.
Now let's pivot to differentiation. This is so important in practice, especially with older adults where it can be tricky.
This is a cornerstone for any exam. Let's break it down. First, age of onset. Classically, T1DM is under 20, T2DM over 40.
But there's a huge catch there, isn't there?
The massive one. About 40% of T1DM cases are actually diagnosed in people over 30, so you cannot rely on age alone.
So what's a more reliable differentiator?
Speed of onset. T1DM is fast, we're talking hours to days, often crashing into DKA. T2DM is much, much slower, developing over weeks or months.
And physical signs? Weight must be a big one.
Huge. T1DM often presents with recent rapid weight loss. With T2DM, obesity is the strong risk factor, so weight loss at presentation is rare.
What about ketonuria?
Common in type 1, very rare in type 2.
Okay, this is where the nice guidance on atypical presentations becomes so useful when things are a bit blurry.
Exactly. NICE says you can diagnose T1DM on clinical grounds in adults if they have what they call typical features. So that's ketosis and rapid weight loss.
And demographic markers, too.
Yes, an age of onset below 50 and a BMI below 25.
And I guess a history of autoimmune disease.
Absolutely. A personal or family history of other autoimmune conditions strongly points towards type 1. This helps us decide when we absolutely have to do the C-peptide and antibody tests.
So based on NICE, when are those tests essential?
You must consider them if you suspect type 1. But there are atypical features. For example, the patient is 50 or older, or their BMI is 25 or over, or the hyperglycemia has developed really slowly.
And the other way around. If you have, say, a 45-year-old you think has type 2 and they're doing well on metformin.
Generally, no need to test further. If the picture fits T2DM and they're responding to oral agents, NCE says further testing is usually not needed.
Let's run through those scenarios from the sources. This is exactly how it comes up in questions.
Let's do it. Scenario 1, 15-year-old, weight loss, lethargy, ketones, random glucose of 14.
That's a slam dunk for T1DM. Age, weight loss, ketones, no more tests needed, start treatment.
Perfect. Scenario 2, a 38-year-old obese man with polyuria, random glucose of 12.5.
This is the gray area. He's in an intermediate age, but has the T2DM risk factor. It's not clear-cut.
So you would?
You have to do C-peptide and autoantibodies. You need to differentiate.
Exactly. Scenario 3, 52-year-old woman, normal BMI of 23, polyuria, polydipsia, and ketones.
Her age is atypical, which puts her in that category, but the ketones and the normal BMI are really pointing to type 1.
So you test her too?
Yes, absolutely. Resolve the doubt with C-peptide and autoantibodies.
Okay, final one. A 59-year-old obese man with polyuria and a random glucose of 12.0.
That's a classic type 2 presentation. Older age, obesity, mild symptoms. No need for further T1DM tests here.
Correct.
So once the diagnosis is clear, we're into long-term management, and the stakes are high. The sources mentioned T1DM can reduce life expectancy by 13 years. That's sobering.
It really is. It's all about managing those micro and macrovascular complications. So NICE guidance from 2015 is very specific. HbA1c needs checking every 3 to 6 months.
Yeah, and the target.
The adult target is tight. It's 48 millimole stool mole or 6.5% or lower.
But it's not a blanket target for everyone, is it? NICE really stresses individualization.
It does, and this is so important. You have to consider the person's daily life, their job, any complications, and critically, their history of hypoglycemia.
Yeah.
Someone with hypo-unawareness or who drives for a living might need a slightly less aggressive target for safety.
And what about self-monitoring? How often should patients be testing their blood glucose?
The minimum is 4 times a day, before each meal and before bed.
And more often in some situations.
Oh, definitely. If they're having more hypos, if they're ill, around exercise, and crucially, during planning for pregnancy, during pregnancy itself, and while breastfeeding.
What are the target glucose levels they should be aiming for?
The aim is 5 to 7 millimole on waking and 4 to 7 millimole before meals at other times of the day.
Let's talk insulin regimens. NICE is very clear about what the modern approach should be.
Yes, it's a firm recommendation for multiple daily injection basal bolus regimens. That's preferred over the older twice-daily mixed insulin regimens. It just offers so much more flexibility.
So within that basal bolus system, what does NICE recommend for the basal, the background insulin?
The regimen of choice is twice-daily insulin detamir. A once-daily insulin glargine, or datamir, is an acceptable alternative, but twice-daily datamir is the top choice.
And for the bolus, the mealtime insulin.
For that, we should be offering rapid-acting insulin analogs before meals. They work much faster than the older soluble human insulins.
Okay, one more drug to mention, metformin. We think of it for type 2, but does it have a role in type 1?
It does. NICE is to consider adding metformin if a patient with T1DM has a BMI of 25 or more. It helps to manage that insulin resistance you can see in overweight type 1 patients.
Right. So to do all this, we really need to understand the different types of insulin. Clinically, it's all about the duration of action.
Exactly. This is essential for designing a good regimen. Let's start with the bolus choices, the rapid-acting analogs like Lispro or Aspart. They're amazing because they start working in about 5 minutes, peak in an hour, and are gone in 3 to 5 hours. Perfect for covering a meal.
And you contrast that with the older, short-acting soluble insulins.
Yeah, they're just too slow for modern mealtime coverage. An onset of 30 minutes, a peak at 3 hours. The timing is all wrong.
Then you have the intermediate ones.
Right, like isofane insulin.
Mm.
2-hour onset, peaks late, lasts about 12 to 18 hours, often used in mixed insulins or as a basal component in some older regimens.
And finally, the ones that are the backbone of modern basal therapy, the long-acting analogs.
Their key feature is that they have a flat, peakless profile. They give stable background coverage for up to 24 hours, ideal for a basal insulin.
So let's name names to make this concrete.
Okay, for the rapid-acting bolus, you're talking insulin aspart, so that's Novo Rapid, or insulin Lispro, which is Humalog.
And for the long-acting basal.
That would be insulin Detamir or Levemir, given once or twice a day, or insulin Glargine, which is Lantus, given once a day.
We should probably just touch on the pre-mixed insulins, even though NICE discourages them.
Sure. Things like Novamix 30 or Humulin M3. They combine an intermediate acting with a rapid or soluble insulin. The problem is they're not flexible, the ratios are fixed, the timing is fixed.
Okay, finally, administration and side effects. Most people inject subcutaneously. Why is rotating the injection site so important?
It's all about preventing lipodystrophy. That's one of the two big side effects. Of course, you also have insulin pumps and IV insulin for emergencies like DKA.
But let's focus on the number one side effect, the most dangerous one, hypoglycemia. What do we teach patients to look for?
They have to know the signs inside out. Sweating, anxiety, blurred vision, confusion, sometimes even aggression. It's a medical emergency.
And if they're conscious, how do they treat it?
They need 10 to 20 grams of a short-acting carbohydrate. That could be 3 or more glucose tablets, a non-diet fizzy drink like Lucozade, or some glucose gel.
What about the emergency plan, if they're unconscious?
Every single person on insulin must have a glucagon kit, and their family and friends need to be trained how to use it. It's non-negotiable.
There are two really critical clinical notes in the sources about hypo-awareness.
Yes. First, having lots of hypos can actually reduce a person's awareness of them. They stop feeling the warning signs.
And you can restore that awareness.
Sometimes, yes, by deliberately letting their blood sugar run a bit higher for a while. You relax that tight 48 millimole target temporarily.
And the second point, it's a key drug interaction.
Beta blockers. We have to remember that beta blockers can mask the warning signs of a hypo. It's a major safety issue.
And the other side effect you mentioned, lipodystrophy?
It presents as lumps or dents in the subcutaneous fat at injection sites. It's prevented by rotating sites.
And if it does develop, what's the clinical problem?
It can cause really erratic and unpredictable insulin absorption. It just makes glycemic control so much harder.
That was a really comprehensive deep dive. We've gone from that acute DKA-like picture through the antibody tests and NICE scenarios, all the way to the fine details of insulin pharmacology and managing side effects.
I think that's the level of depth you need for these high-stakes exams. We've covered the key thresholds, the reasons for basal bolus, and the essential patient education points. It's about being prepared for accurate, safe clinical practice, and we wish all candidates the very best of luck in your test.
So to leave you with something to think about, we've talked about this very strict HbA1c target of 48 millimominal or 6.5%, driven by the need to prevent long-term complications. But we also talked about the very real risk of reduced hypoglycemic awareness. So how do clinicians, in practice, balance that aggressive drive for control against that risk? What does that mean for how we counsel patients and set their individual targets day to day?